Good day everyone, so for today I will discuss to you about the salient points in the Supreme Court decisions. So number one is the contraception as the governing principle. So the RH law's overarching principles is the promotion of contraception as a key aspect of reproductive health. So contraception is emphasized as a fundamental component of the RH law's objectives to improve reproductive health outcomes and empower individuals in family planning decisions. So the second one is right to life grounded in natural law. The right to life is inherent in every person and is not dependent on any specific law, custom, or belief system. So this highlights the foundational nature of the right to life and its recognition as a fundamental human right that transcends legal frameworks. The third one is the prohibitions of abortifacients. Abortifacients which induce abortion or harm a fetus are strictly prohibited under the RH law. So the clear definition and prohibition of abortifacients underscore the law's commitment to protecting the sanctity of life from conception. So the fourth one is protection of unborn life. Contraceptives that harm or destroy the life of the unborn from the conceptions are not permitted. This provision ensures that contraceptive methods do not compromise the life or well-being of the unborn, emphasizing the law's commitment to safeguarding life. The fifth one is the regulation of contraceptive distribution. Contraceptive drugs or devices can only be sold or dispensed by licensed entities with a medical prescription. Regulation of contraceptive distribution ensures proper oversight and adherence to medical guidelines, promoting safe and responsible use of contraceptives. Number 6 is FDA approval for contraceptive inclusion. Inclusion of contraceptive in the essential drug list requires FDA approval to ensure safety and non-abortifacient properties. The rigorous evaluation process by the FDA underscores the importance of scientific scrutiny and safety considerations in approving contraceptive methods. Seventh one is consensus objections for healthcare workers. Healthcare workers have the right to object on conscience grounds to artificial contraceptions and are not obligated to refer patients for contraceptive services. So, this provision respects healthcare workers' ethical beliefs while balancing patients' access to reproductive health service, ensuring that individuals' rights and beliefs are upheld. Number 8 is the consensus objections for hospital and healthcare providers. Non-maternity, specialty hospitals, and religiously affiliated healthcare providers can also refuse to refer patients for contraceptive services based on conscience objections. So, this extends the consensus objection provision to healthcare institutions and providers, recognizing their right to uphold ethical or religious beliefs. So number 9 is consensus objection for government healthcare workers. Government employment healthcare workers can also refuse to refer patients for contraceptive services based on conscience objections. So the inclusion of government healthcare workers in the consensus objection provisions ensures consistency in respecting ethical beliefs across healthcare settings. So number 10 is exception for emergency cases. Consensus objection does not apply in emergency cases where the mother's life is at risk. This exception prioritizes the preservation of life in critical medical situations and ensuring timely access to necessary healthcare services. Number 11 is spousal consent for irreversible contraception. Both spouses must consent for a married person to undergo irreversible contraception. The requirement for spousal consent underscores the importance of mutual decision-making in family planning matters within a marital context. Number 12 is parental consent for minors. Parental consent is needed for minors to receive family planning services except in emergency surgical procedures for life-threatening situations. So these provisions balances parental involvement in minors' health care decisions with the need to ensure access to critical services in urgent medical scenarios. Number 13 is exclusion of private educational institution. Private educational institution can be excluded from mandatory reproductive health programs based or academic freedom grounds. This provision respects the autonomy of private educational institutions in shaping their curriculum and policies related to reproductive health education. Number 14 is religious and ethical grounds for local government employees. Local government employees performing non-medical functions are not compelled to implement the RH law based on religious or ethical objections. So these provisions acknowledge accommodates the religious and ethical beliefs of local government. Local government employees ensuring respect for diverse perspective and implementation of the law. Number 15 is principles of no abortion and no coercion in family planning. So the RH law upholds the principles of no abortion and no coercion in adopting family planning methods. By emphasizing these principles, the law aims to promote responsible and voluntary family planning practices that prioritize the well-being of individuals and respect for life. So, these salient points in the Supreme Court decisions on the RH law highlight key provisions related to contraceptions, abortions, conscientious objection, spousal and parental consent, and ethical considerations in reproductive health services. So the discussions accompanying each point provide insights into the rationale, implications, and ethical considerations underlying these provisions, reflecting the complex interplay of legal, ethical, and healthcare considerations in the realm of reproductive health policy and practices. So let's go now to the implementation. Implementation of the RPRH Law 2015. So full implementation of the Responsible Parenthood and Reproductive Health Law began in 2015 under the Department of Health, involving national and regional implementation teams collaborating with various government agencies, civil society organizations, and development partners. So the initiations of full implementation signifies a comprehensive effort to operationalize the provisions of the RPRH law and expand access to reproductive health services across the Philippines through multi-sectoral collaboration. So the second one is the activities of implementation teams. Implementation teams engage in policy development, procurement of drugs and supplies for underserved populations, training of RPRH service providers, advocacy for RPRH services, community education, and mobilization. Program financing and monitoring of RPRH law implementation. The diverse range of activities undertaken by implementation teams reflects a holistic approach to addressing reproductive health needs, encompassing service delivery, capacity building, advocacy, community engagement, and program oversight. So the third one is allocation of funds. An amount of 40.70 billion was allocated for the implementation of the RPH law, with 21.74 billion from the DOH, 12.80 billion from the Philippine Health Insurance Corporation or PhilHealth, and the remainder from the Commission on Population or POPCOM. So, the significant financial allocation underscore the government's commitment to supporting the effective implementation of the RPRH law, ensuring adequate resources for service delivery, capacity building, advocacy efforts, and program sustainability. So, the details provided highlights the key aspect of implementation of RPRH law, including the commencement of full implementation in 2015, the activities of implementation teams, and the allocation funds to support the successful rollout of reproductive health services in the Philippines. So, that's all. Thank you.